Thank you very much, Professor Forestier. Thank you very much, Dr. Knecht, for inviting me to this outstanding meeting. I would like to talk about adjuvant radiochemotherapy, and I would like to focus on the role of chemotherapy in the adjuvant setting. In addition, I want to talk about the role of drugs in preventing side effects of radiochemotherapy, and I want to talk about the role of prior surgery on the results and on the side effects and late effects of radiochemotherapy. Since many years it is well known that adjuvant radiation therapy has a role in those patients who have a positive NEC after initial surgery, at least in those patients with an N2 NEC, or as Dr. Myers told us yesterday, in patients with extracapsular nodal disease. In these results, you can see that the addition of radiation therapy to surgery improves as well local control and cause-specific survival. Similar results have been published in those patients who have positive margins after initial surgery. And again, you can see that post-operative radiation treatment improves local control in these patients. In addition, there are results that you can improve local control in those patients with great tumors. And presently, accepted risk factors for local regional recurrence after radical surgery are great tumor sizes, lymph node involvement, at least at the N2 NEC and extracapsular extension, and positive margins after surgery. And as a consequence of these results, many patients with these risk factors have been irradiated and local control have been improved. In recent years, there have been several attempts to improve local control and overall survival by the addition of chemotherapy. And as you can see here, most of these patients have been treated additionally with cisplatin. In these two trials, 100 milligram per square meter on day 1, first week, third week, and fifth week, this was very similar. And in this first published trial in 1996, patients were given 50 milligram cisplatin per square meter per week. If you look at this data, you can see that local control has been significantly improved in these two trials. In this trial, probably the patient number was too small to have sufficient power. The local control has been improved from about 50 to 70% to 70 to 80% in all of these three randomized trials. Overall survival has been improved in this small trial with very low overall survival in the radiotherapy-only arm. And in this trial, the European ERTC trial published by Bernier in the New England Journal of Medicine 2 years ago, overall survival has been improved from 40 to 50%. In this trial, overall survival was insignificant between radiotherapy alone and radiotherapy plus cisplatin. The radiation dose which has been given after radical surgery was between 65 and 70 gray, but most patients have been treated with 66 gray. These are the data in detail which have been published by Bernier for the ERTC trial. And here you can see at 5 years, progressive-free survival was 50% for radiochemotherapy and about 40% for chemotherapy, and overall survival was 60% for radiochemotherapy and less than 50% for radiotherapy alone. These are the main data on which standard strategies are defined. There have been other attempts to improve the efficacy of radiation therapy in the post-operative setting. And I would like to show you this trial, which has been performed in Germany some years ago. And in this randomized trial, the aim was to improve local control and survival by the addition of EPO. And as you can see here, the addition of EPO does not improve survival, but gets worse results than placebo. This trial was initiated on the basis of the fact that patients with low hemoglobin levels have a worse prognosis than those with good hemoglobin levels. And it was very surprising that the addition of erythropoietin and the increase of the hemoglobin levels in the patients with EPO did not have an effect, but had worse effect in the whole group of patients. I come back to that problem afterwards. The addition of chemotherapy to radiation therapy in the adjuvant setting leads to an increase of toxicity, and particularly of the problems of mucositis. We have talked about that yesterday, and as you can see here in the ERTC trial, additional chemotherapy leads to a significant increase of mucositis, and there is one additional side effect which normally not seen in RT alone, that is vomiting, and the other side effects are very similar. But there is no doubt that increasing toxicity is seen with additional chemotherapy, and particularly with more aggressive regimens. The cisplatin application forms you can see here, most of these patients have been treated with 100 milligram per square meter or with 50 milligram cisplatin weekly. There is no doubt that more intensive chemotherapy leads to increased toxicity, but there is no data that more intensive chemotherapy leads to better results. So my opinion is at the moment there is no rationale for increasing toxicity and intensity of chemotherapy at the moment in the adjuvant setting. In Göttingen, we prefer to give 6 milligram per square meter daily, as it has been published by Jeremy, and Volker Budach commented on that yesterday. Are there possibilities to reduce toxicity? This, to my knowledge, this is the only data which show that the additional application of a drug reduces toxicity in adjuvant radiochemotherapy. These are the data which have been published in the Journal of Clinical Oncology, and as you can see here, this is the development of patient benefit questionnaire for patients with amifostine and for RT alone, and as you can see that the quality of life is better after the application of amifostine. And interestingly, in this study, there was no effect on amifostine on the efficacy of radiation therapy. There has been another study which tested the hypothesis whether the additional application of GCSF to radiation therapy, with or without chemotherapy, improves the tolerance to radiation therapy. And in this study, which has been published in 2001, GCSF was given in one arm and in the other a placebo, And as you can see here, those patients who receive G-CSF additionally to radiation therapy have worse local control than those patients who didn't receive G-CSF. G-CSF was given with the aim to reduce toxicity. And these results are very similar to the EPO study. Again, cytokines had worse effects on local control. There have been other attempts to reduce toxicity of radiation therapy and radiochemotherapy, and this is one study which addressed the effect of nutrition support. And there were 3 groups. One patient group received baseline nutrition support before treatment initiation. The second group received nutrition support during treatment only. And the third group received no specific nutrition support. And the results are very surprising. They are currently published in the Head and Neck journal. The mucositis was not significantly different, but there was a trend in favor of the BNS group. Weight loss was significantly less in the BNS group, but the difference was very small, but it was significant. But most interestingly, there was no effect of nutrition support on the local control. That means the improvement in weight loss had no effect on the efficacy of radiation therapy. In contrast, you can see that the baseline nutrition support before treatment initiation was worse than the patients who received no specific nutrition support. What has been proven is that pilocarpine can maintain and protect unstimulated salivary gland flow. You all know that, but again, there was no positive impact on the quality of life outcome for patients taking pilocarpine. We can conclude from this data that probably the impact of xerostomia is not as important for quality of life of the patients as we feel. In summary, we can conclude that the addition of specific drugs to improve the tolerance of radiation or radiochemotherapy has very limited efficacy. I think the most important point, and we have discussed that yesterday, is the role of local regional treatments and the role of sophisticated surgery and sophisticated radiation therapy. One of these aspects have been discussed yesterday by Thomas Wendt, and these are the rules which have been published by Gregoire 2 years ago about the clinical target volumes radiation therapists have to choose to make adequate treatment. And you can see here for every disease site, these regions have been defined. And these regions have been defined on the basis of data from neck dissections. And I think we have to re-evaluate these clinical target volumes, and it is urgently needed that we discuss with the surgeons which side of the neck, particularly of the neck and of the tumor site, has to be irradiated to improve local control by radiation therapy. The choice of the clinical target volume is essential for the rate and for the severity of side effects and late sequelae which the patients have. And in addition, sophisticated RT techniques are needed to improve the efficacy and the tolerance of radiation therapy. Finally, I want to come back from a specific Göttingen view to the role of initial surgery on adjuvant treatment. And as you know, I talked about that yesterday. In Göttingen, many patients with advanced tumors are treated initially with laser surgery, and